right quality test, that is the sensitivity test of the pulp. With this, once we have arrived to a diagnosis, then we'll go ahead with individual pulp therapies, right? Whenever the caries is affecting or the caries is occurred onto the enamel, okay, there is nothing which patient complains about. It is just a white spot lesion, then it goes to the cavitation. Still, the patient doesn't have much problem until and unless the caries reaches to the dentino-enamel junction. Once it has been reached there is a sensitivity or the pain, what we can say. And as it continues, we are well versed with the sequelae of dental caries. So, whenever there is a transient pain, as we have seen in reversible pulpitis condition, whenever the caries is there in the superficial dentine, and routine removal of the carious tooth structure followed by a restoration will do with a protective base, which will prevent the pulpal inflammation by the overlying restorative materials or any inserts which are happening to the pulp due to the food lodgement or the presence of microorganisms or their toxins. Okay. So, whenever there is a dental caries which has entered into the dentine, right, and it is deeper, and when we judge that, whenever we are going to take out this amount of whole carious dentine, there might be chances of exposure of the pulp. That is the situation when we go for this indirect pulp capping. Then, what is this indirect pulp capping? Indirect pulp capping is defined as a procedure wherein small amount of caries is retained in the deep areas of the cavity to avoid the exposure of pulp, followed by placement of medicament and restorative material of the carious dentine and encourages the pulp recovery, which is given by the Engel, and it is done with Rationale to arrest the carious process and avoid the conditions conducive to the formation of reactionary dentine beneath that is a stained dentine, that is the affected dentine, and remineralize the remaining carious dentine. Okay, this is the rationale of indirect pulp capping, wherein which removal of the soft carious dentine is done and there is a placement of a medicament, usually the calcium hydroxide, to stimulate the reactionary dentine to be formed. Usually in indirect pulp capping, with tertiary dentin, that is the reactionary dentin which has been formed. So, what are the indications? Tooth with a deep carious lesion. Pulpal inflammation has been judged to be minimal, that is reversible pulpitis conditions. Complete removal of the caries would cause the pulpal exposure. So, what are the contraindications? Any signs of pulpal and periapical pathology, that's what we have discussed. History of spontaneous pain. History of tenderness, it is the tenderness to the percussion. This is a sign what we have to elicit. Abnormal tooth mobility, soft leathery dentine covering a very large area of the pulpal cavity, a very large area of the carious cavity. So, these are the contraindications of it, and then this is the procedure, that is how it has been done. The zone of affected dentine exists between the outer infected dentine and the pulp. Then what we need to do, we have to remove the infected dentine with the help of a large spoon excavator or a large round bar, seal off the site with the calcium oxide, restore the tooth, allow the reactionary dentine to form and preserve the vitality of the tooth. So, in that what will be done is the margins of the carious cavity, that is it has to be extended to the healthy dentine and the enamel, so that the restorative material will have a good coronal seal and the soft infected dentine has to be removed to the maximum of its extent. And whenever there is a doubt that pulp exposure is going to happen if the whole carious dentine has been removed, then that is left out over there and placement of a medicament like calcium hydroxide is done, and which is followed by a restorative material, that is either a glass enomer material. On top of it, you can go for a composite restorations. Okay, if it is involving more than two surfaces, even we can go for a stainless steel crown restorations. So, coming to the direct pulp capping, we need to remember one thing here. is whenever the excavating the caries, if there is a pinpoint pulp exposure which has taken place in the course and it is judged to be a carious pulpal exposure in a primary tooth, then that is not a candidate for direct pulp capping. Direct pulp capping can be done when there is a pinpoint exposure due to traumatic injuries or iatrogenic exposures where it is not a carious pulpal exposure, right? Particularly when we are dealing with the primary teeth. AAPD guidelines clearly state that it should be a pinpoint exposure less than a millimeter and it should be either iatrogenic or should be a it should be a carious exposure. So, what is the definition given by the COPEL? It is defined as the placement of a medicament or a non-medicated material on the pulp that has been exposed in course of excavating the last portions of the deep dentinal caries or as a result of trauma. Particularly, the carious exposures are not taken into consideration when we talk about the primary teeth, and it can be taken into consideration when we go for a permanent teeth. That is an immature tooth that we are going to deal in a further presentation. Okay, so the rationale for the direct pulp capping being to achieve a biologic closure of the exposure site by deposition of hard tissue barrier, that is the dentin bridge between the pulp tissue and the capping material, thus walling off the exposure site and subsequent healing of the pulp. The indications being of small mechanical or traumatic pulp exposure which are less than 1 millimeter in diameter with minimal bleeding, and where we can control the bleeding easily and it needs to be irrigated properly. Insertion of a medicament like calcium hydroxide. Nowadays, there is the routine use of MTA has given a very good success rate compared to calcium hydroxide in the primary teeth over the site to stimulate the calcific bridge formation and to maintain the vitality of the tooth. The contraindications being any signs of pulpal or periapical pathologies, excessive bleeding from the exposure site, purulent or serous exudate, history of spontaneous and nocturnal pain, tenderness to percussion, abnormal mobility, interradicular radiolucency, and the direct pulp capping, in that the pulp capping material is, as we can see in this diagram, the pulp capping material, that is an MTA which has been placed and it has been restored with a restorative material. It can be an RMGIC, it can be a composite material. Limitations in the primary teeth, right, that we have discussed. Calcium hydroxide pulp capping is not so found to be not so successful, particularly in the primary teeth. That is causing an internal resorption or calcifications and chronic pulp inflammation, that is a continuation of it, and even the necrosis of the pulp has been seen in the literature. So what are the reasons why the direct pulp capping is not so recommended or not so successful in the primary teeth? In McDonald in 1956, he said that the localization of the infection and the inflammation in the primary teeth is poorer than the permanent teeth because of high vascularity and high cellularity, right? And the second which has been said is the high cellular content in the primary teeth responsible for failures. Primary pulp responds more rapidly to the effects of dental caries, even the restorative materials or pulp capping materials, than the permanent teeth. So, and one more thing which has been said by Kennedy in 1985, that the undifferentiated mesenchymal cells may differentiate into odontoclast rather than the formation of odontoblasts in response to caries or pulp capping material, which could lead to internal resorption in the primary teeth. However, the use of the newer materials like mineral trioxide aggregate, that is MTA, and even the bioglass has given the better results comparative to that of the calcium hydroxide direct pulp capping. So, till then we were talking about the tertiary dentin, a reparative dentin and a reactionary dentin, right? And let us see about what exactly the differentiation between the two. The tertiary dentin, which has been formed in response to any stimulus, if the stimulus is mild, right, and there is no injury to the odontoblast particularly, that is resulting into a reactionary dentin formation. That is, whenever the mild stimulus is there, the surviving post-mitotic odontoblasts are going to form this dentin, which is regular, and usually the procedure of indirect pulp capping induces this reactionary dentin. However, aggressive stimuli, and whenever there is a pulp exposure, there is damage to that portion of odontoblasts and their processes, everything is gone there. So whenever there is a medicament which has been placed, which is in direct contact with the pulp, so there is an aggressive stimulus to the underlying undifferentiated mesenchymal cells to form them into odontoblast-like cells to perform the formation or the wall of that infection with the calcific bridge formation. That dentin is not much regular, and that is irregular in its microscopic structure, and it is usually been seen in a direct pulp cap, as we have seen in the previous discussion. When they have been pulpally involved, either due to a carious exposure or a traumatic injuries or any other reasons, then we need to go for the apexogenesis. This is particularly the histological terminology. Right, it is defined as the treatment of vital pulp by capping or pulpotomy in order to permit continued growth of the root and closure of the open apex. Desired in vital exposures if radicular viability can be maintained. Rationale being maintenance of the integrity of the radicular pulp tissue to allow continued root growth. So it is physiological process of root development in vital infected tooth. Normal pulp or pulp tissue with minimal inflammation is present. If we take out the coronal pulp completely, whenever we are going to maintain the vitality of the tooth completely, that is, we call it as direct pulp cap, and it has been, if the only radicular pulp of the portion has been retained, that is the pulpotomy. All right. So what are the contraindications? Avoid reimplants tooth, crown root fractures, unfavorable horizontal root fractures, and non-restorable teeth. This is one of the cases which I'm going to show you that is a pre-operative radiographic apex, traumatized tooth, pulpal involved tooth. It was pulpotomized, and you can go ahead and see that there is continued root development. You can see the calcific bridge which has been formed, and after 15 months follow-up, you can see the apex is closed and there is a continued root development. What are the treatment outcomes? It is continued root formation, tissue formation of the healthy calcific metamorphosis. Failure shows the cessation of the growth with periapical pathosis. With failure, complete root canal treatment with